Hello dear students. Today we are going to learn about the development of human embryo during the first week of gestation. This is the timeline showing the how embryo develops during the first week of gestation after fertilization, which occurs in the ampulla of the uterine tube. A unicellular zygote form which has diploid number of chromosomes, and this is the pronuclear stage on day 0. This is on the day of fertilization. After 24 hours it divides and form a 2-cell structure, and again after next 24 hours it divides to form 4-cell structure. Then it forms 8-cell structure on day 3, and on day 4 it forms a mulberry like structure with 16 cell number, which is known as morula. And after the formation of morula, there is influx of the fluid in the from the outer cell layer to form a cystic cavity known as blastocele, and this whole structure is known as blastocyst. And after this blastocyst formation, it reaches to the uterine cavity on days 5 or 6. It reaches to the uterine cavity and it gets expanded. Due to this expansion, the zona layer detaches or sheds from the remaining blastocyst, and blastocyst then hatches out from the zona and it attaches to the uterine cavity or decidua. Here in this diagram we can see that how cleavage of the cells occurs. Initially 2-cell stage, then 4-cell stage, then 8-cell stage forms, and then compaction occur on the day 3. This compaction is necessary for the development of human embryo. It segregates the cells from in two parts, the outer cell mass and the inner cell mass. And inner cell mass is known as embryoblast and outer cell mass is known as trophoblast. From inner cell mass the future embryo will develop, and from trophoblast the future placenta will develop, which nourishes the embryo. So both are necessary for the development of normal human embryo. And here after the formation of 16 cell stage, which is the morula, and then after the formation of morula, this zona pellucida start to shed, and blastocyst releases from the or hatches out from the zona pellucida, and there is influx of fluid from the outer cell mass, and it forms the blastocele and it gradually expands, and this is known as blastocyst. And this blastocyst, under the influence of fibroblast growth factors, it differentiate the inner cell mass differentiate into the epiblast, hypoblast and anterior visceral endoderm. So there is differentiation, and also the axis determination of the cells occurs. Axis determination mainly the dorsal. The epiblast is placed dorsally, so it is epiblast is dorsal, and hypoblast is ventral. So this vertical and dorsal axis determination and the cranial and caudal axis determination also occurs, because there is development of AVE, anterior visceral endoderm formation. So both dorsal, ventral and craniocaudal axis are determined during this stage of the development. Now come to the clinical significance and clinical abnormalities which can be seen in the first week of gestation. This is the Hydatidiform mole or gestational trophoblastic disease. When a sperm fertilizes a ovum which is empty or does not have the female pronucleus, then uh, it is it forms only the trophoblastic tissue, and no there is a formation of only the trophoblast or placental tissue, but there is no formation of any embryo tissue or fetal tissue. This is known as complete mole, and it presents as a cluster of grapes. This seen as a cluster of grapes, and these grapes are nothing but the villi which are swollen up due to the water, hydropic villi. Here in the histopathological examination, we can see this is the trophoblastic tissue, outer trophoblastic tissue, and these are the in these are this is the space filled with the fluid. So it is known as hydropic villi. Hydropic villi with the trophoblastic proliferation. So in the H mole we can see these hydropic villi with the trophoblastic tissue proliferation. In in the H mole, patients presents with a positive pregnancy test due to the secretion of beta hCG from the placental tissue or the trophoblastic tissue, but there is no embryoblast form. So we cannot see any embryo tissue in complete mole. However, we can see few embryonal tissue in the partial mole. This disease usually occurs in the females with ages around 36 or 44 year of age, and hydropic villi with trophoblastic proliferation is the histopathological feature. The USG finding is the snowstorm appearance of the H mole in the USG. This is the snowstorm, like snow is falling, or it is also known as honeycomb uterus or snowstorm. These are the differences between the complete and partial moles. Complete mole is of paternal origin, that is androgenesis. It forms with the either by the fertilization of an empty ovum by a single sperm which undergo endo-reduplication. That means a single sperm fertilizes a ovum without its pronucleus, and only the sperm nucleus undergo reduplication to form the diploid chromosome number, and it is the most common pathogenesis. Second, we can see the two sperm fertilize a single ovum which do not have pronucleus, so it is the empty ovum. It can be seen in 20% of cases. On the other hand, a partial mole, which is less common than the complete mole, in this both paternal as well as maternal genetic material can be seen, and the pathogenesis is the fertilization of an ovum with the two sperm or a diploid sperm which fertilize the ovum. A diploid sperm which fertilize the ovum. Usually sperms are haploid, but a diploid sperm which fertilizes the ovum can be a cause of the partial mole. Karyotype, these are diploids. Complete moles are diploids, 46XX or 46XY, but these are paternal origin only. However, the karyotype of partial mole is either triploid, 69XXX, 69XXY, 69XYY, or tetraploid. Embryonic material is absent in complete mole. However, it can be seen in the partial mole. And trophoblastic proliferation is diffuse in case of complete mole, and it is focal in partial mole. SCG levels are much higher than expected for the gestational age in the complete mole. However, it is uh, slightly raised in case of partial moles, and uterine size is large for gestation because of enormous tissue proliferation in the complete mole, and uterine size is small for gestation in case of partial moles. Complications are more common in case of complete mole, such as thecal lutein cyst, pregnancy-induced hypertension, and gestational neoplasms like choriocarcinoma are more common in complete mole, and these are less common in partial moles. ISC for P53 or immunohistochemistry for P53 is positive in partial moles and negative for complete moles. Now, second abnormality which can be seen in the first week of gestation is ectopic pregnancy. Ectopic pregnancy is normally the implantation occurs in the uterine cavity, and further embryo development is seen there only, but normal implantation occurs on the posterior wall of the uterine cavity. But in cases of ectopic gestation, the the fertilized ovum does not move from the ampulla, and it implanted only there only, and this is the ampullary tubal pregnancy. It is the most common type of ectopic pregnancy, or it moves slightly further on the other side, so on the inner side of the tube, but does not reach to the uterine cavity. So other are the tubal non-ampullary type of ectopic pregnancies can occur, and the most dangerous is the if it this implantation occurs in the interstitium portion of the uterine tube, which is the narrowest portion of the uterine tube. So the complications like excessive hemorrhages are more common in the interstitial implantations. Other sites of ectopic pregnancy include the cervix, ovary, or reverse peristaltic movement of uterine tube can cause the uh, can cause the uh, can cause and the reverse peristaltic movement and the reverse peristaltic movements of the uterine tube can cause the expulsion of the fertilized ovum out of the uterine tube into the abdominal cavity, and here we can see abdominal ectopic pregnancies. So thank you for listening, and these are my references.